Hello, everybody. The topic of discussion is pathology and treatment of stimulant abuse. The United Nations Office on Drugs and Crime estimated that worldwide 35 million people suffer from drug use, while only 1 in 7 get treatment. In this presentation, I will go over background and go over the simplified mechanisms of stimulant addiction, major complications, and treatment strategies. The stimulants include cocaine, amphetamines, and amphetamine-like substances, for example, khat. Cocaine is produced from coca leaves. Methamphetamine is produced from ephedrine. This is advertisement from 1885 that cocaine is available in a local drug store. Cocaine was listed as controlled substance in 1970. In 1983, possession of equipment and precursors for methamphetamine production was prohibited. Methods of use. Cocaine. Crack is free-base and highly addictive. Cocaine is diluted by dealers with sugar, procaine, or other additives. Therefore, purity varies. Most common method of use is snorting, finely chopped powder, least dangerous, smoking, subcutaneous and intravenous injection, most dangerous since it's associated with stroke, myocardial infarction, and death. Khat, fresh leaves of native Catha edulis in Africa, also has amphetamine-like effect from cathinone. Once dried, it is converted to the far less powerful stimulant norepinephrine and cathepsin. Mechanism of action of cocaine binds to the dopamine transporter and inhibits the reuptake of synaptic dopamine. Administration results in dose-dependent increases in extracellular levels of dopamine, blocks the reuptake of norepinephrine and serotonin. Basically, the mechanism of action is similar to antidepressants, but far more potent. Mechanism of action of methamphetamine. Methamphetamine decreases dopamine reuptake and promote dopamine release via the dopamine transporter, also taken up intracellularly, enhancing dopamine release. Designer amphetamines such as MDMA, MDEA, MMDA, and DOM also cause the release of catecholamines and serotonin, implicated as the major neurochemical pathway for hallucinogens. Neurobiological mechanisms of addiction, role of brain's natural rewards and motivational systems. Stimulant-induced increases in extracellular dopamine and glutamate play a critical role in addiction, including changes in gene expression and synaptic plasticity. Neural areas involved in stimulant addiction include reward, such as nucleus accumbens, ventral pallidum, motivational orbitofrontal cortex, memory amygdala hippocampus, impulse control prefrontal cortex, cingulate gyrus. Neural areas involved in stimulant addiction include reward, nucleus accumbens, ventral pallidum. Motivation is attributed to orbitofrontal cortex. Memory with amygdala and hippocampus. Impulse control, prefrontal cortex, cingulate gyrus. Here are the relevant areas involved in addiction, including prefrontal cortex, nucleus accumbens, amygdala, etc. Dorsolateral prefrontal cortex is attributed to executive functioning such as planning, motivation, foresight, feedback. Orbitofrontal cortex is attributed to remorse, insight, and judgment. A number of different neuronal circuits and neurotransmitters have been implicated in the process of addiction. In addition to dopamine, the neurotransmitters glutamate, GABA, opioid neuropeptides are important in this circuitry. Dopamine is released into the nucleus accumbens by axons from ventral tegmentum area. Target neurons in the nucleus accumbens have long axons that project to distant regions and release enkephalin, dynorphin, or GABA. These neurons have an extensive dendritic tree that can accommodate massive projections from prefrontal cortex. This enables nucleus accumbens to funnel processes and transmit cortical information throughout the reward system. So in summary, projection from ventral tegmentum area go to amygdala, nucleus accumbens, and prefrontal cortex. Role of genetics in addiction. Monozygotic twins have higher concordance rates for stimulant dependence than dizygotic twins. Mice bred to lack the glutamatergic mGlu5 receptor will not self-administer cocaine. Neuroimaging data in primates and humans indicate that the reinforcing effects of cocaine are negatively related to dopamine D2 receptor levels. Low levels of D2 receptor availability predict high rates of cocaine self-administration in primates. Following repeated cocaine self-administration, D2 receptor availability is decreased by 15 to 20%. This may lead to a vicious cycle. A subset D2 receptors maintain these low levels even following months of abstinence. Suppression of adult hippocampal neurogenesis via cranial irradiation before drug taking significantly increased cocaine self-administration. Addiction alters the brain's natural reward and motivational system. A recent study reports that long-term potentiation was similar in the rats that had learned to self-administer cocaine, food, or sucrose, but with a critical distinction. The increase in long-term potentiation due to cocaine persisted for up to 3 months of abstinence, but the increase in response to natural rewards dissipated after only 3 weeks. During the late withdrawal phase, a person may experience brief periods of intense cue-induced drug craving. These periods of intense cravings are high-risk times for relapse. Cocaine and amphetamine intoxication have similar symptoms. The differences in clinical presentation are due to the respective half-lives of the drugs. Cocaine 40 to 60 minutes, methamphetamine 6 to 12 hours. Although binging is a common pattern of use for both drugs, the difference in half-lives allows some methamphetamine users to maintain low levels of intoxication for a longer period of time. What complications these drugs can have. Chronic administration of either drug can induce a paranoid psychotic state. Methamphetamine-induced psychosis can be long-lasting and may recur in the absence of further drug use. Individuals may be at risk of acting violently in response to frightening delusions common in induced paranoia. Amphetamine use can also result in disorientation, confusion, and anxiety. Myocardial ischemia and infarction are the most serious complications of stimulant abuse. Chest pain is the most common symptom in cocaine users presenting to the emergency department. 7 to 25% of patients presenting to emergency departments with non-traumatic chest pain will screen positive for cocaine in their urine. 6% of these individuals will have enzymatic evidence of myocardial infarction. Cocaine acutely increases the risk of acute myocardial infarction by a factor of 24 in otherwise healthy individuals. Increased risk appears to be unrelated to amount of cocaine used or frequency of use. 50% of those with cocaine-related myocardial infarction will have no evidence of atherosclerotic coronary artery disease. Cocaine ingestion results in coronary vasoconstriction, increased myocardial oxygen demand, increased thrombus formation, left ventricular hypertrophy, and reduced left ventricular systolic dysfunction are all associated with cocaine use. Stimulant use is a risk for stroke because it can lead to elevation in blood pressure, vasculitis, vasoconstriction, massive intracerebral hemorrhage, even in younger people. Seizure is another complication, 3 to 8% in cocaine abusers, less common in methamphetamine abuse. Result of using methamphetamine for approximately 10 years. A, a particular concern has been the increased methamphetamine use among men of all sexual orientation with an accompanying increased risk of HIV infection. Methamphetamine and ice in particular is associated with increase in sex drive, decreases in sexual inhibition, increase in risky behaviors such as sharing needles, unprotected sex, anal sex. Methamphetamine facilitates female sexual behavior and enhances neuronal activation in the medial amygdala and ventromedial nucleus of the hypothalamus in rats. Treatment. Psychosocial and behavioral approaches are the mainstay of treatment in stimulant-dependent individuals. There are currently no medications with FDA approval for the treatment of cocaine or amphetamine-dependent individuals. Contingency management. Contingency management applies the principles of positive reinforcement for performance of desired behavior consistent with abstinence. A recent study demonstrated that all groups had a significant reduction in methamphetamine use during the treatment. However, participants receiving contingency management were retained in treatment for longer and provided more drug-free urine samples than those receiving only cognitive behavior therapy. Matrix model, stimulant treatment protocol. It is organized into a set of manuals, provides the structure and content for a multi-element 3-visit per week, 16-week outpatient treatment followed by weekly follow-ups for 1 year. In matrix model, CBT for individuals and groups, family education, motivational interviewing, and 12-step program participation. The results of a recent study suggest that the matrix approach produces outcomes that are equivalent at 1 year post-treatment to contingency management. Behavioral therapies, including cognitive behavioral therapy and supportive expressive psychotherapy, have been shown to help retain people in treatment and can lead to abstinence. Pharmacological treatment. Bupropion shows promise as a pharmacotherapy for preventing relapse among methamphetamine-dependent individuals. Disipramine, imipramine shows reduction in cocaine use in depressed patients. In a double-blind, placebo-controlled trial, citalopram combined with behavior therapy reduces cocaine use. Topiramate reduced cocaine consumption in cocaine-dependent subjects. GABA agonists such as baclofen and GABA reuptake inhibitors, for example, tiagabine, have shown greater reduction in cocaine use than the placebo group. Modafinil Modafinil's stimulant properties may reduce the craving, dysphoria, and anhedonia experienced during the Modafinil's stimulant properties may reduce the craving, dysphoria, and anhedonia experienced during the initial stages of stimulant abstinence, as well as improve cognitive functioning. Another line of investigation includes the use of sustained-release stimulants with less abuse potential, such as methylphenidate, as maintenance strategies, much like the use of methadone in opiate dependence. In a Finnish study, methylphenidate reduced methamphetamine injection in an early-stage trial. A more recent line of investigation includes development of active or passive immunization. In summary, psychopathology of stimulant use involve both polygenetic factors and availability of the drugs. Psychosocial and behavioral approaches are the mainstay of treatment in stimulant-dependent individuals.